Well, I'd like to thank the organizers for the kind invitation to moderate the next session. It's indeed a great honor to introduce Tom DeMeester to give the next talk on progression of GERD on PPIs, cause, consequence, and proposed management. Tom, as you all know, is the former chair of surgery at USC. What you may not know is he and I are both from Michigan, so we have this bond, so I know he won't run over on his time. Tom, please.
Lights, do you have the button there to push?
No,
lights?
there's a...
Yeah, this one, right? This one? Yeah. Is my, yeah, good. Thank you, my friend. I appreciate this opportunity to speak with you and tell you this story that we have in regards to the progression of GERD under PPIs. I'd like to acknowledge, though, before I get started, is our pathologist, Barrett, who I think is here this morning, because he dedicated a lot of it. We've been together for the last 20 years and worked well together, and it's been really helpful in understanding this problem. You also give you some studies that both John Lipham and Steve DeMeester did, and that's part of my presentation here that pushes on this issue, and Dr. Ozzie, who also did the work on some of the means by which this happens. And of course, there's a lot of other fellows that are around that maybe dipped at different times of this. So let's begin. Progression under therapy. Years ago, I was in Germany giving a talk, and the gastroenterologist stood up and said, "Tom, you might as well just stop operating. We've got a pill that takes care of this. It's not going to be a problem anymore for people." Well, things have changed after a half a decade or a half a century, and now we have a problem of progression. Progression, this is the sequence of progression that a lot of people talk about: NERD, healable esophagitis, difficult to heal, Barrett's, and esophageal cancer. Many people circle in here, and they're not diagnosed because endoscopy is not done for people with NERD very often. But those studies that have shown that these people circulate between NERD and healable esophagitis while on PPIs. Some break out and get to where it's difficult to heal their esophagitis, and that's an indication that things are progressing. These people lead to Barrett's, and Barrett's to cancer. Now, there's a lot of studies on this, but there's two really significant ones, and they come from the European experience, which I think is a little bit more controlled than what you would find in an open society like ours. After 5 years, this is the ProGERD study, which showed that after 5 years, 12% of patients progressed to difficult to heal esophagitis, the sort of the first indicator of this problem. 10% then go on to Barrett's esophagus. This study is unique. It's from Sweden. I know the investigators personally. Some of them were fellows with me, and they used the same motility that they did before the study and at the end of the study. It's a unique study because the follow-up was for 20 years. 43% of the patients progressed to difficult to heal esophagitis, and 28 of the patients progressed to Barrett's. So the longer you're on these pills, the greater the opportunity is to progress. What was unique about the study, and was a trigger to our thinking about it, was that they did motility with the same device when the patient started and at the end of the study. And what they found is the differences between patients treated with PPIs who progressed and those that did not were two things that they could tell. One, the LES abdominal length decreased by 1 centimeter in those that progressed. those who didn't progress didn't have that change. And the time the pH was less than 4 in the supine position increased by 11%. So they lost some sphincter, and they increased esophageal acid exposure. That stimulated us to start to really look at this problem. Now, this is the study of the sphincter as done in the perfusion days, and which we still do, because it gives us a very accurate understanding of the sphincter's length. This is a motorized pull through the sphincter at 1 millimeter per second. So we can get a good estimate of the length of the sphincter. The important thing is that the overall length and the abdominal length are two critical factors in sphincter function that have not been looked at over the years. Pressure is actually least important. Length is very important, as you'll see unfold. The abdominal length is critical in protecting you against rises in pressure in the peritoneal cavity to protect you from reflux. As you know, if you pick up a bag of cement, the pressure in your abdomen goes up to 350 millimeters of mercury. And you have to have a sufficient abdominal length to be able to respond to that. The overall length is more critical in protecting you against challenges of gastric pressure to the sphincter. Now, that sphincter fails in two ways. There may be other dialogues that say a little different, but we have found that it's a dynamic failure in many people. By dynamic failure, we mean that the length of the sphincter gets shorter as gastric distension occurs. So when it gets short, you get a shorter length, the sphincter becomes temporarily incompetent. As soon as the gastric distension is relieved, or gastric dilatation without pressure, same thing happens if you have adaptive relaxation of the stomach. If that leaves, then the sphincter regains its length. So it's dynamic, it's not permanent. The other failure is permanent, and that happens when the portion of the distal esophagus of the sphincter area is damaged, and it's permanently short, as you see here. Now, over the years, we've developed and measured very carefully what is critical measurement is, what a critical measurement is. Now, for independent component failure, what do I mean by that? I mean, if this component of the sphincter is short, really short, it overrides all other components. It doesn't make any difference what they are. The sphincter is going to fail. It's an independent measurement that tells you the sphincter is going to fail, is failing. They are an abdominal length less than 2, an overall length less than 2, and this overall length less than 2, and abdominal length should be less than 1. I'm sorry for the mistake. And this is LES pressure less than 6. Pressure isn't really that important. You'll see. And then there's an adaptive, additive effect of the component failure. That means where a component is partially shortened and the abdominal length is partly shortened, and the two together, when additive, can make a failure. So it's multiple failures of the components. This is that Ken Wang showed you the other day. Chang shows you what happens when you have these failures to acid exposure. This is pH score. This is normal subjects, less than 14. If you have a dynamic failure of the sphincter, your pH score is around 30. This is in some 406 patients. As you progressively have more and more components fail, you see the exposure go up, and the pH score is higher, representing that greater esophageal exposure. Note the most common disorder, short overall length. Second is short abdominal length, and the least is pressure. So for over years, we've been looking at pressure, and it's been difficult to really make the switch. Now here's the important study before I leave this part of the talk. It's a prospective study, and it shows you exactly what's happening to your patients. This is a fella, Klaus, took 128 patients, put them on full PPIs for 12 months, and if they developed symptoms of recurrent symptoms or esophagitis, they were considered to be a failure. Now, this is how he structured the study. He took a group of patients who had a normal sphincter and a normal body, a group of patients who had a defective sphincter and a body, and here's his defectiveness, a pressure less than 8, abdominal length less than 1.2. Or they had both defective, length and sphincter. They put them on PPIs, and you can see if you had a normal body and a normal sphincter, PPIs did extremely well. There was only 7% failure. So the message to take home is that PPIs love a good sphincter. Okay? If you had a defective sphincter but a normal body, about 38% of those patients failed. If you had a defective both, which of course is probably like Barrett's, 79% of them failed. So you can see as the sphincter determined the effectiveness of your PPI. That's why it's still very important today. It's interesting that none of the patients really complained of failure until after 3 months. So you really have to know and follow your patients for 3 months before you make this decision that they're worse or so. Most of them don't complain about it. Now I'm going to switch to, I'm just picking the highlights of this so you can get a grasp of what this is like. Now I'm going to switch to the composition of the refluxate and its pH. That's the other determinant of this disease. The first is the sphincter. The other is the composition and pH of the gastric juice. We measured that in 273 patients using the BiliTech when it was available, combination with pH, as you see here. This shows that about 56% of your patients have bile or acid reflux, 14% bile only, and 30% acid only. The first question that pops into your head is, why is that so? How can that be so? Well, here you got so much bile coming back that it completely overrides all your acid. And all you do is you see bile in the stomach at an excessive level that we did with a normalcy or abnormalcy of these probes. Here you have acid only. In that situation, you're making so much acid that any bile that comes back precipitates out. I'll expand on that in a minute. In this situation, you would have times during the 24-hour period where you have acid come out, then pretty soon you would have a lot of bile, and then you go back to acid, and when you total it up for a 24-hour period, both constituents are abnormal. This is very important to realize that, and we don't think about that when we give an antacid PPI. Now, this is a critical factor that a lot of us don't talk about or think about. And this is the pH, gastric pH here, and this is the percent duodenal juice coming back into the gastric juice and then the mixture. Now, if you have a pH less than 2 in your stomach, which is what it normally is, you can mix that to about 50% of bile before you go above 2. So there's a great buffering capacity of the acid in the stomach to any bile coming back from the duodenum, if you have a good acid pH in the stomach. If you just change that to a pH of 1.5, you can see that it happens with only 20%. If you change the pH in the stomach to 2, it almost immediately stays in solution and doesn't precipitate out. When it's in solution, it's in its combined form, acid and its base. In its confined form, it's soluble. And I haven't got time to go on with this, but I can say this to you, because it's in that form and it doesn't have a charge, it can get into the mucosal cells and have a concentration 7-fold that which is in the lumen of the stomach or esophagus. And that screws up, and I haven't got time to go into it. We could talk for the next 30 minutes just on what that does intercellularly. When you get up to a pH around 6, then it's completely dissociated, charged particles. That's the way it is in the liver, and the body handles it beautifully. So when you give someone a PPI, you're moving them from here to here. So we got to think about that, what that does if they're refluxing bile. Very important in understanding progression of disease. This shows you the different mucosal damages done, the risk of esophagitis, the odds ratio between bile alone, acid alone, or bile and acid. Not much difference, really, for esophagitis. It is statistical. It's a little bit more for this if you do the statistics. But when you get over here to look at Barrett's, the risk of Barrett's, bile alone, acid alone, bile and acid, you see there's a 15-fold increase in the chance of getting Barrett's when you have combined reflux. So we need to think, by giving these pH medication, how much are we shifting the pH of the stomach, keeping bile in solution, allowing it to reflux, and causing this damage. What happened? You're up. I'm all done. Gastroenterologist down here says I'm up. This shows you what the bile reflux does, or different types of reflux does, to the actual structure of the sphincter. You see here, this is sphincter resting pressure. When you get down to a mixture of acid and bile, it is below the critical factor of 6, gradually progressing down with the other types of reflux. Here you see with overall length, bile again mixed goes below the important length. Abdominal length, the same thing. Little effect on the contraction amplitudes of the esophagus itself. So, in summary, the steps to destruction of the LES is a dynamic loss of the sphincter initially, exposure of the esophagus to a mixture of acid and bile, mucosal injury, inflammation and destruction of the LES length, permanent loss of the LES length, and then a higher necessity for medication to keep the patient going asymptomatically. Now, I want to switch. I'm doing pretty good. I want to switch here to now the status of the LES and GERD. This is on the basis of our analysis of 918 patients, positive 24-hour, and we looked to them to see what the status of their sphincter was. And about half of them have a normal sphincter, which is dynamically failed, and the other half have a damaged sphincter. So obviously, before these patients came to us, there has been damage done to their sphincter, and in a large number of them that came to us, there was no damage done. This is a critical thing to to look at, because how do these get over to here on therapy? And we'll take a look at that. It happens because of effacement. This is kind of known as another name, such as transient sphincter relaxations. I don't like the word relaxations. I just say transient sphincter losses. But anyway, we call it effacement. And when the stomach is distended, or when the stomach opens up with non-pressurized dilatation with meals, the sphincter shortens as the sphincter is taken up into the fundus. And you see the red lining here represents the mucosa, and the mucosa, of course, is exposed to the acid pocket in that area, and it is subject to damage. This shows you the change in 11 normal people that we studied. Dr. Ayazi did this. Here you see the average sphincter here in these patients. So this group was about 4.5. And while they ate 750 cc meal, it dropped below the critical factor of 2, where the sphincter became inefficient. So you can see there's a big change that happens in the length of the sphincter with eating. This is reflected in almost every normal person that we study. This shows you the actual length of the sphincter and its shortening for each of the subjects. Everyone shortened with distension. And here you see a patient that got really short. When he gets really short, he loses confidence easy. And this particular patient, reflux, it was not a patient, it was a normal subject, reflux, similar to what you would expect would happen with transient sphincter relaxation. But I don't believe they're relaxations. They're due to effacement and unfolding. So together you see here what happens. This is the sphincter area. And when you distend the stomach, the sphincter gets about half its length, a little less. And you notice what happens to the pH. The sort of pink is the pH before distension, and the green is the pH after distension. And you see that the pH, less than floor, moves up. Here's the pH, moves up into the sphincter during the time of distension. Now I moved on to a discovery that changed a lot of thinking. This is the presence of cardiac mucosa that develop in the cervical esophagus after esophagectomy. When we take the upper stomach out, bring a tube of stomach up and hook it to the esophagus up in the neck, you follow these patients. Here we followed 42, or I guess how many is that? I can't see. Developed in 10, this was 24 patients. And you will see in about 42% of them, a little lesion coming up into the cervical esophagus from the anastomosis. If you biopsy that, that is cardiac mucosa. A number of investigators have reported this. A lot of people do work with Chagas disease, which is also sort of a form of achalasia, very distended esophagus. They do this. People live for quite a long time, and almost all of them get this. When we looked at this, we did a number of studies to see how that compared with the cardiac mucosa we saw at the bottom of the sphincter in people who have reflux disease, and it's almost identical genetically. And this is what happens in the bottom of the sphincter. This is the basic lesion of GERD. It's cardiac metaplasia. We were stimulated to do that on the basis of that experience in the cervical esophagus. And here you see a little area of cardiac mucosa. When you put the scope down, turn around, you'll see this little area of cardiac mucosa as the first evidence of damage of the sphincter. We took patients where we could not find cardiac mucosa to those that we could, and we looked at them. This is some 300 patients at the hallmarks of reflux disease. Overall length of the LES, 3, 2.2. Abdominal length, 1.6, 1. Resting pressure, 13, failed LES, permanent failed LES, 27, 62. pH less than 4, 1.1, 6. Esophagitis. And the patients with intestinal metaplasia, none, of course, no cardiac mucosa, 11%. So you can see by just biopsying and seeing the presence of cardiac mucosa at the very end of the esophagus, you got signs that that sphincter is in trouble. And you got reflux disease confined to the sphincter area. You don't know about it yet. It's coming. Then you look at some people and you see this more dramatically, and you'll see how this is a much bigger sort of scalloping. And if you do a study on that sphincter, what you'll see is this. You will see a very nice upper border. This is a four measurements made in a sort of three-dimensional way, and you see each of the 4 measurements are exactly equal on its upper border. But look what happens at its lower border. Here you see the end of one right here. Here you see the end of another right there. Here you see the end of another right there, and the 4th one here. It's a very sawtooth pattern at the lower border of the sphincter, which, of course, is damage from cardiac mucosa. Now, this is probably the most important slide I'm going to show you, because it brings it all together. Here you look back on the GE junction, you look at this, and if you're not taking your time, you'll assume that that is the end of the esophagus. This is a squamocolumnar junction, you'll say, and you'll move on. But if you turn a narrow band imaging on it, you will see that there's these islands of squamous epithelium that are being chopped up by cardiac mucosa that is invading in this area. And this is where the esophagus once ended, and this is where it is, you think it is. So this here is actually esophagus. There's another important thing on this. That portion of the esophagus, which has been invaded with cardiac mucosa and squamous disruption, is flat, just like the curvature of the stomach. And it's very easy to assume that this is all stomach, but actually a portion of this is esophagus. And we get confused, and that's the first step of confusion that we have. I'll show you another in a moment. When you do block histology on this, this is what you see. This is the squamous epithelium in a normal person. This is oxonic epithelium, the normal epithelium that lines the stomach. And you see here, they abut each other. There is no other mucosa between the squamous and the oxonic mucosa of the stomach. In this patient, a refluxer patient, you see, here's the squamous epithelium. Over here's the oxonic epithelium. This was there, but now has been chewed up by cardiac mucosa. This is cardiac mucosa. And this forms a gap. We call it the sino-oxonic gap. That's where all the action in reflux disease takes place. That's the war zone. Now, something special happens there. Here we see a diagram to illustrate this. This is the LES. Here you see the squamocolumnar junction, and it's gradually rising. It's rising because cardiac mucosa is right on the border and is gradually eating up into the squamous epithelium with reflux disease and effacement. And the second thing that happens is because of that, this cardiac mucosa weakens the sphincter, and it balloons out like the stomach, like the previous slide showed you. And everybody gets confused where the end of the sphincter is or where the end of the esophagus is. And oftentimes you go fast, you come here and you see this biding out and you say, we're in stomach, boys, we're in stomach. And you're confused. This is a very dynamic area of confusion. And then there's one more thing that confuses us. As this length of cardiac mucosa gets longer, it forms 3 layers. The bottom layer is accentic cardiac epithelium. It's epithelium that is working towards to become epithelium like the stomach. It has developed parietal cells, and it's moving to become stomach. In the middle, it's just cardiac epithelium, confused which way to go. And on the top is cardiac epithelium that thinks it's in the intestine someplace and is turned on to become cardiac intestinal metaplasia. And here is our squamo-oxonic gap. If you put that picture into your head, the next time you scope, you'll begin to really see and understand the action that's going on down here. Now, another very important discovery that was made by Sindez, the only person I know in the world that did this very carefully with his endoscopy and motility at the same time, determining the level or the height of the squamocolumnar junction. Early in disease, in his controls, the squamocolumnar junction was about 2 centimeters from the bottom of the sphincter area. But as disease progressed, no injury but reflux, few isolated erosions, multiple longitudinal confluent erosions, and then we start getting into the Barrett's area as it climbs up. And so the squamocolumnar junction is moving up during the disease. Marking things by the squamocolumnar junction leads to error. How many of you place your pH probe based on the squamocolumnar junction minus 6 centimeters? You're putting it beyond the area of risk, getting acid to it. Either you're missing, you're starting at a different point and going higher. You got to think about that. There's a problem in measurement. What happens, you see, is as this little segment of cardiac mucosa begins to get larger where it forms tongues, and then less than 3 centimeters in length, and then greater than 3 centimeters, the growth of Barrett's, the following things have happened. Overall length has continued to drop to where now it's gone almost. Abdominal length has dropped. Sphincter pressure has dropped. It's a progression slowly as the little cartoon I showed you plays out. And what happens along with that is intestinal metaplasia. You can get it here in 9%, tongues at 25%, 49%, and 97%. Intestinal metaplasia increases. Put these pictures into your mind. Now, this is one I think of the most startling and helpful studies that I have read. Because this is from the pro-GERD study that I started to talk to you about. I showed you it, pro-GERD study of the progression of disease. Here he had 171 symptomatic GERD patients who were endoscopically normal and had microscopic IM biopsies at the squamocolumnar junction before any therapy. He biopsied the squamocolumnar junction. At that point, he picked up cardiac mucosa, which had intestinal metaplasia in it. And it was microscopic. Microscopic, couldn't see it otherwise. After 4 to 8 weeks of PPI therapy, 128 of these patients had a follow-up endoscopy and biopsy of the squamocolumnar junction, and all had persistence of the microscopic intestinal metaplasia in the cardiac mucosa. On continued PPI therapy, an endoscopy with biopsies of the squamous columnar junction was performed at 2 and 5 years, and about 30% of those patients, 28.5, showed progression to visible Barrett's. This shows you the length of Barrett's that they were able to see visible, going from microscopic to visible Barrett's under therapy. So the conclusion is asymptomatic patients on PPI who have a normal endoscopy and microscopic IM on biopsy of the squamous columnar junction are at risk for visible Barrett's. Now, just before that, in our studies, we decided we would attack microscopic IM at the GE junction, microscopically at the squamous columnar junction. We did that with a Nissen fundoplication on a study, getting approval from the person to have it done, explaining to him all the issues. We did a Nissen fundoplication, and in 73% of those, we completely had regression of the microscopic intestinal metaplasia. Gone. If we did that, our control were visible, people with visible lengths of Barrett's, and we did Nissens on them, and in only 4% did we get loss of intestinal metaplasia. Then just recently, Dr. John Lipham here and his group took 29 patients, read this paper just off the press, 29 patients with ultra short segments of Barrett's, close to microscopic, and microscopic IM on biopsy of the squamous columnar junction were treated with LINX sphincter augmentation. Follow-up biopsies showed complete regression in 82% of them at 1 year. 2 studies, 2 separate investigators, one using a more early sphincter augmentation procedure, the other one, the Nissen, showing complete regression of cardiac mucosa IM at the junction, where it starts. So with that, I give you a new policy. Patients who have GERD should come in and go on PPIs. If they have partial or non-response, you can double dose it. If they have partial or non-response, have manometry and 24-hour study early. If 24 hours positive, do an endoscopy early. If they already got visible Barrett's, you take it from there. If they don't, then look for persistent or progressive esophagitis. It's persistent or progressive. If you do a motility study, you'll see a loss of overall LES and an abdominal length, loss of abdominal length. Go to augmentation of the sphincter right away and get the patient off the pills. For one reason or another, you're changing the pH in that stomach, that's not good. And to keep the growth keep the mucosa from coming intestinalized. If it's normal, but a biopsy of the squamous columnar junction, that should be done right away. And microscopic IM is seen, exclude Helicobacter, which is a rarity, and have the same procedure. Get them off the pills and augment their sphincter. If they're normal, but their biopsy of the squamous columnar junction shows carditis, follow them yearly with an endoscopy. Do a motility and pH to see how their stomach is, how their sphincter is functioning. And if there's a failure in the sphincter or they develop intestinal metaplasia, operate on them and do a sphincter augmentation procedure. One of the great things of this meeting is to get together and decide together on logic what's the best way to take care of these patients. Because I want you to remember, oh, I missed the last slide here. My message, it's right there. Don't know if I can get one more slide. There we go. My message is this. If you stop the formation of Barrett's, you can stop progression to cancer. No Barrett's, no cancer. It's time we start to do that. If a patient goes from just reflux disease to Barrett's, there's a 400-fold that he could get cancer. Stop it at its beginning. Thank you for your attention.